Hello, my dear doctors. So, today I have decided to make a detailed video about uh, the cardiology cases. I'm going to discuss about aortic stenosis today. And this discussion will be on the new PACES format. As you know that PACES now in future will be known as PACES 23, and last time of examination 2023 will be the new there will be new setup for the PACES. There are some changes because they have introduced two consultation station, and this is a kind of long case actually, which we go through during our undergraduate examination, and it consists of actually 15 minutes of history taking, examination, answering any relevant queries, and there is 5 minutes for the examiner to ask the questions. So the preparation is different. You have to be careful, take a focused history, focused examination, and then you should have an idea about the treatment, management, because the examiner definitely will ask you about the management and the differential diagnosis. So this is totally new for the PACES 23. So let's start our presentation today. So let's talk a bit about the history. So you will get the scenario once before you enter the PACE station, and there will be brief history written there. So this is a 67-year-old female, and she presented to her general practitioner with 5 months of dyspnea. She originally ascribed this to just getting older, but now she becomes dyspneic when mobilizing around the shop and is unable to walk the dogs without stopping frequently. This was never an issue before. When inquiring about syncope, she reports not having any syncopal events, but on one hot day she felt like she was going to faint when she was cleaning the house and had to sit down. She also recalls feeling dyspneic with only mild exertion when she had a viral chest infection a few months ago, but did not seek medical attention as the dyspnea resolved with the resolution of infection. Continuing the history, she reports no associated chest pain or palpitations. She reports no orthopnea, PND or peripheral edema. She is an ex-smoker of 38 pack years, but quit 10 years ago. Otherwise, her past medical history and family history are unremarkable. So these are the salient features, and once you see it, maybe you'll get a scenario that patient is having a history of 5 months of dyspnea, then immediately you'll be thinking about the causes, and most likely the two systems you'll be focusing on, the respiratory system and the cardiac. Obviously, you will not think more about doing the CNS examination or the GI examination, because this system is more relevant to the symptoms, and you have to do the focus examination. Let's dissect a bit about our history. Okay, so this is a 67-year-old female and 5 months of dyspnea. Now remember, the most common valvular pathologies are MR and aortic stenosis. So most common is either mitral regurgitation or aortic stenosis, and the aortic stenosis is usually, further we can say, it is a calcified aortic stenosis, calcific aortic stenosis, and about 10% of the people older than 85 years will have aortic stenosis. Now the patient says there is a 5 months history of dyspnea. So this patient actually has presented with chronic progressive dyspnea. Now the differential for this presentation include not only cardiologic causes, we'll be thinking about the respiratory causes as well, such as COPD and interstitial lung disease. So we'll be thinking about these two possibilities as well. So dyspneic when mobilizing around the shops. So this means this history is quite useful. When someone presents with dyspnea, it is useful to identify their current exercise tolerance. Mobilizing around the shops would most likely be less than kilometers worth of walking is quite useful, as it identifies that this dyspnea is limiting the patient's usual activity of daily living. And it was never an issue before. So her current exercise tolerance is significantly decreased compared to her pre-morbid exercise tolerance. It's important to compare the baselines. You wouldn't know unless you remember to ask. Another important point, suppose if you're thinking about cardiac causes, is we'll inquire about the syncope. And she reports not having any syncopal events, but on one hot day she felt like she was going to faint when she was cleaning the house and had to sit down. Now remember, this point is very, very important. Now remember the classic triad of aortic stenosis, when we talk about triad of aortic stenosis, is actually syncope, angina, and dyspnea. You can remember it by the mnemonic SAD: syncope, angina, and dyspnea. And these three symptoms should always be attained and quantified on history, as their presence carries prognostic significance. How it carries the prognostic significance? Suppose the patient just presents with angina, have a 5-year survival. If the patient has syncope, then it is 3-year survival. And patient with dyspnea from congestive cardiac failure has 2-year mean survival. So patient has not had syncope, but has an episode of pre-syncope. And we know that aortic stenosis results in fixed cardiac output states, and whenever there is a period of stress or hypovolemia, patient may experience syncope or pre-syncope. So in this case, it was likely because of the dehydration on a hot day that results in pre-syncopal episode. Okay, coming down our dissection, she recalls feeling dyspneic with only mild exertion when she had a viral chest infection a few months ago, but did not seek medical attention. Very, very important point. This is another clue. Remember, degenerative calcific aortic stenosis is asymptomatic for a long period of time. Approximately, we can say 10 years. So in periods of physiological stress, however, the symptoms may become apparent. Okay, so this was the detailed discussion about the first part. Now, she also reports no associated chest pain or palpitation. This is a very point, because patient with aortic stenosis may present with angina. Around half of the patient would have concomitant coronary artery disease, and the other half angina due to increased oxygen demand, because there is hypertrophied myocardium and altered coronary flow. Then these are the important negatives. She reports no orthopnea, paroxysmal nocturnal dyspnea, or peripheral edema. Now, remember that this patient is giving history. There is no signs of left heart failure apart from exertion dyspnea. Smoking status is very important. One must ask about the smoking. She is an ex-smoker, but quit 10 years ago. Now remember, this smoking is an independent risk factor that increases the progression of aortic stenosis. Calcific aortic stenosis, usually it occurs from a combination of degenerative and inflammatory process. So smoking, it causes an inflammatory state, promoting calcium deposition. So it stiffens which in turn actually stiffens the leaflets and reduces the valve area. Past medical history and family history are remarkable, very, very important in the history of any system. Actually, it is quite important, especially in the cardiovascular and respiratory system. So complete your cardiovascular examination, cardiovascular history by ascertaining all traditional risk factors for ischemic heart disease, hypertension, dyslipidemia, diabetes, and family history of IHD. Also, worthwhile asking about a past history of rheumatic fever. Past history of rheumatic fever. Because prior to the advent of antibiotics, rheumatic fever was the most common cause of aortic stenosis, and usually it will cause some fusion, fibrosis, and stiffening of the aortic cause, resulting in stenotic valve. So that is enough about the history. I think we have dissected it and discussed in detail about the history. Now, once you have taken the history, you will move to the examination. Okay. So this patient obviously is going to do the general physical examination first. The patient appears well with no signs of increased work of breathing. She's not obese. Sometimes patient can have an obesity hypoventilation syndrome, so it's important to see whether the patient obese or is within the normal weight. Her heart rate is 70 beats per minute, is regular. Her blood pressure is 150/95. Her respiratory rate is 16, saturation 90, and she is afebrile. Now this part actually maybe you don't, if the blood pressure, the instrument is available, you take the blood pressure, otherwise you can ask the examiner. Respiratory rate you can count, saturation oxygen also you can ask, and ask about the temperature as well. It's called full set of observation. You can say I like to take the full set of observation. Okay. So then we proceed to examination of the hands. The hands revealed no clubbing or nicotinic stain. Now this patient has presented with dyspnea, which could indicate for the doctor to look for the peripheral signs of respiratory disease as well as cardiovascular disease. Clubbing would indicate interstitial lung disease, and nicotinic stain would indicate COPD. Okay, then you move on and you check the carotid pulse. There was an anacrotic carotid pulse, and JVP is not elevated. Characterizing the pulse actually helps in differentiating between aortic stenosis and aortic regurgitation, and this is best done at the carotid artery or brachial artery. Radial pulse is weak and not the best for characterization. If the stenosis is severe, there may be a slow upstroke, and this slow upstroke is called anacrotic pulse. Or the peak of the pulse may be late, it's called tardis, or have decreased amplitude, it's called parvus. So if the pulse has a delayed peak and a small volume, it's called pulses parvus at tardus. Okay. The apex beat is displaced to the 6th intercostal space, just lateral to the mid-clavicle line, and is pressure loaded. So apex beat is displayed inferiolaterally from its original position on the 5th intercostal space, mid-clavicle line. It is because of the ventricular hypertrophy. Can be characterized as pressure loaded if it is sustained or forceful. Anyhow, in the examination, if you are able to demonstrate that apex beat is displaced, that is already enough actually. And pressure loaded, maybe you can appreciate, maybe you can't, it doesn't matter. So then we do the auscultation. Auscultation of the chest reveals a harsh crescendo, decrescendo, ejection systolic murmur, which is loudest in the upper sternal edge, with the murmur radiating to the carotids. Now, the classic description of the murmur of aortic stenosis is crescendo, decrescendo, mid-systolic ejection murmur, and is best heard at the right upper sternal border that radiates to the carotids. It is a mid-systolic murmur. as the left ventricular pressure only exceeds the systemic pressure, and the pressure gradient of the aortic wall during mid-systole. In addition to this, A2 must know about the A2. So A2 may be soft or may be absent. Okay. Now there is radiation of the murmur to the carotids. So radiation of the murmur to the carotids is very, very important because it excludes the pulmonic stenosis, aortic sclerosis, and hypertrophic obstructive cardiomyopathy, because these are all causes of ejection systolic murmur. So one should appreciate, if you got ejection systolic murmur radiation of the carotids, then you are almost 100% sure that the patient has aortic stenosis. Okay. And the murmur is accentuated with the patient breathing out, leaning forward, and squatting. So examination usually normally asks the patient to sit up, breathe out, and lean forward. So murmur, you can hear the murmur clearly. It does not change in intensity Valsalva maneuver. Normally we don't do Valsalva maneuver in the examination, but you can do it also. Okay. Now, auscultation of the lung reveals clear air entry with no dullness to percussion. So important to listen to the lungs because we want to see here for any creps which can be there because of the cardiac failure, or if you're thinking about the respiratory causes, then maybe you can hear some fine creps or coarse creps. So it's worth mentioning about the lungs. She does not have any peripheral stigmata of infective endocarditis such as genuine lesion, oscillate nodes, or splinter hemorrhages. We're going to look at it. And there was no peripheral edema. Now remember, this is your sequence of doing the examination, and while you're doing the examination, you just keep all the whatever positive and important negative findings in your mind, because this will help you with your presentation. When you are going to present the case, you will give a very brief history, tell your positive findings, important negative findings, and your differential diagnosis. Or if you're very sure, then you can just straight away say that, in my opinion, this patient has got aortic stenosis. Okay, let's move on to the investigations. Examiner will ask you what investigations you like to do. So obviously, first of all, you want to do an bedside test is important, like ECG. So ECG in this case shows sinus rhythm with a heart rate of 74 beats per minute, and this marked. You will see in ECG. They will ask, maybe they will not show you ECG, but maybe ask you what findings you will see in the ECG. So you expected to see left axis deviation, left ventricular hypertrophy, maybe mildly prolonged QRS, or T-wave inversion, or some ST segment depressions. So these are all ischemic changes, hypertrophy changes, all these you can see. Next test you want to do is chest X-ray, and normally we want to look for any cardiomegaly or any post-stenotic dilatation of the aorta, if you can appreciate it. And you will also like to do some serology, and it is commonly unremarkable in aortic stenosis. Transthoracic echo was performed as an outpatient with so severe aortic stenosis, mean pressure gradient of 60 and aortic valve area of 0.7. So obviously you're going to further tell that I like to do the transthoracic echocardiogram, and I will be looking for a pressure gradient and as well as the aortic valve area. There is also moderate left ventricular hypertrophy in the echocardiography, and left ventricular ejection fraction was 45%, and patient also went to coronary angiography to rule out concomitant coronary artery disease. So basically you have to tell about the investigations, what investigations you're going to do, how you're going to approach, and briefly why you want to do it, and then it will be okay. All right. Now we come to the management part. because the examiner may ask you about how you're going to proceed, how you're going to proceed or manage this patient. So this one also, management part, you have to be very systematic. So management, I'll try to divide into different sections. Like acute management, first of all, it is uncommon for patient with aortic stenosis to have emergency presentation. Usually they imagine outpatient basis. Those with acute symptoms can present with angina, maybe have cardiogenic syncope or acute pulmonary edema. So the specific, anyhow, this one I'll discuss with further cases, then you can see that one. So this patient presented with progressive dyspnea without signs of decompensation. Thus, she should be suitable for an urgent referral to cardiothoracic clinic for consideration of surgical aortic valve repair. So symptomatic patients are usually referred to the cardiology clinic, and then they will assess that how they want to proceed, whether they want to repair the valve or want to do the valve replacement. So it depends on them. Now some patients, we just do the monitoring. Patients who do not meet criteria for surgery, they require regular surveillance with serial echo. Remember, the aortic valve area on average decreases by around 0.1 centimeter per square per year, which increases the pressure gradient to around 7 mmHg per year. Even if the patient do not require an aortic valve replacement, they will require an intervention later. So monitoring is very important when we are discussing the management of the patients. Coming to the medical treatment in patient is limited as no medications are known to have prognostic benefit or delay disease progression. Medical treatment, when indicated, is for the symptoms management. Like for angina, beta blockers can be used. For heart failure, we can use the loop diuretics. And digoxin, well, it could be used for patients in heart failure. It can help with actually dyspnea in heart failure. And the beta blockers, we know that slows the heart rate and decreases the overall oxygen use. They are only used if angina is the predominant symptom. Loop diuretics, well, they decrease the preload and to prevent any exacerbation of heart failure that develops in aortic stenosis. Need to be balanced with the risk of hypovolemia. This patient can tip into hypotension and develop the syncope. What about the intervention? Now, the choice of intervention actually depends on the age, level of function, and the patient comorbidities. For children, very young adults with congenital aortic stenosis or those who are unfit for surgical replacement, balloon valvuloplasty can be considered. For those who are elderly, more than 75 with inoperable aortic stenosis, transcatheter aortic valve replacement can be an option. Otherwise, surgical valve replacement is the surgery of choice. Remember, this balloon valvuloplasty is really is not done now because there is a high chances of restenosis, and it carries a quite significant risk. Okay, surgical aortic valve replacement. Surgical replacement would be recommended treatment for the patient, for this patient particularly, because she presented with symptomatic aortic stenosis and is fit enough to undergo the surgery. Actually, it is the only definitive treatment for severe aortic stenosis. Aortic valve replacement, they requires median sternotomy and all of its associated morbidities. When we talk about the valve replacement, we talk about the bioprosthetic valve and the mechanical valve. Bioprosthetic valves, remember, do not last as long as mechanical valves, but also do not carry with them the systemic thromboembolic risk that mechanical valves do. Patient requires follow-up on discharge to assess for late complications and valve function. So these patients should be routinely followed up post-surgery to ensure adequate valve function and to assess the complication like prosthetic valve thrombosis, conduction disorders, and paravalvular leaks. Transcatheter aortic valve replacement. This is a relatively new non-surgical intervention where a bioprosthetic valve is implanted within the native aortic valve, and this is mostly done via femoral arterial access. But in patients with difficult anatomy, a direct transaortic or transapical approach may be required. It improves effective aortic valve orifice area and hemodynamics and the better survival rates than medical management. It's a good alternative for patients who are deemed too high risk for surgical aortic valve replacement. So, current evidence demonstrates that it improves the prognosis for patients who traditionally have no treatment options for their inoperable severe aortic stenosis. In high-risk patients, survival rates are similar with the transcatheter aortic valve replacement and surgical aortic valve replacements. Percutaneous balloon aortic valvuloplasty. Well, this is a non-surgical palliative treatment option for patient with aortic stenosis. It has a percutaneous approach where a catheter with a balloon is threaded through the aortic valve and inflated, so opening the stenotic valve. However, it does not alter the prognosis, and there is a high rate of restenosis. So this was the brief discussion about the aortic stenosis, and I tried to cover with the history, examination, and everything. And normally the questions they ask will be which I've already discussed with you. So that's it for the aortic stenosis consultation station. I'll come up with the more videos about the consultation station. So till that time, just take good care of yourself, and please post any comments if you think that anything need to be improved or you want any other topics. Just let me know. Thank you very much, and I'll see